on this 10th of August 2021. The meeting is being held virtually and is hosted by the Utah Department of Health Center for Medical Cannabis based in Salt Lake City. Public notice of this meeting was provided as required under Utah's open meeting laws, and it was posted on the Utah Public Notice website. In compliance with Utah's open meeting laws, this meeting is being recorded, and a recording of this meeting will be posted to the Public Notice website no later than 3 business days following the date of this meeting, and written minutes will also be prepared of this meeting. Approved minutes will be posted to the Utah Public Notice website no later than 3 business days after board approval. In terms of the roll call, Melanie, we will need to update the roster, so I'll go ahead and work through with that with you. But as of right now, officially on the virtual meeting, we have myself, Dr. Red, Dr. Smith, and Dr. Zender, and presumably joining us in a few minutes will be Drs. Heath and Carlson. There are a number of guests on the call that are available on your screen or by phone. And if you are on the phone only, please do notify Melanie or in the chat your identity so everybody can be duly recorded. Everybody, the public is welcome, and all proceedings of this meeting are fully available and transparent. We do ask everybody who's not a board member to wait to be called upon to address the board. You can enter comments in the chat, and Melanie will keep an eye on that and manage the chat room. Sort of the approach I'd like to take is that after every segment, if there's public comment, entertain those comments. If they're brief, if they're more lengthy, we'll defer them till the end so we don't go over. And as a courtesy, please place yourselves on mute during the meeting until it's time for you to speak. And we will now proceed with the agenda. So thank you for tolerating those formalities one more time. And so again, I want to welcome everybody. I really do appreciate everybody taking their time to invest themselves and engage in this process. I do want to thank you, Melanie Shepard, who has newly joined to guide us from an administrative standpoint in keeping us all organized. And I'm sure over the course of the next few weeks to months, as we settle back in, we'll get ourselves on track again. It's always these changes and are always a bit difficult, and so everybody bear with us. Appreciate your patience. We do have a quorum for voting with 4 board members, so we will proceed with a motion to approve the June minutes unless there is any discussion. So if any discussion, please raise those, and otherwise, may I have a motion for approval?
Is that Red? I moved to approve minutes.
Okay, second, anyone?
I'll second that.
And any opposed? Okay, we'll assume then all are in favor.
Who was the second? Sorry.
The second was Brian Zender, Dr. Zender. Okay. The other approval that's required now is for the autism guidance document. We've had many months to review this and to refine them, and I want to extend appreciation to all those who participated. Mark Viner was on the, oh, there you are, Mark. There you are in the corner. Thank you for your comments and inputs, as well as all those on the board and others. I think we now are in a position to officially approve those. I see that from the document, at least that I pulled up, there is I think unofficially a date of approval. So unless I missed something, and please correct me in my imperfections. I do believe we still need to vote on that. Is that correct, Sarah and Rich? Yeah. That's a
Yeah,
yes.
I think there was an approval based on, that change being made, but I think it's good to do a final approval.
Yeah, I think Rich clarified that we do need to do this
Yep.
during a publicly held meeting. So it's not feasible to do it by, or it's not allowable by email. So
Yep.
may I hear from a board member a motion to approve this as a finalized guidance document for this round until it comes up again, and maybe another year, 2 or 3, depending on.
I move approval of the guidance document.
Thank you, Brian. Is there a second?
Just a quick question. This is the guidance document for Alzheimer's or for autism?
Autism spectrum
Okay.
disorder.
Good, thank you. I
And
second.
Just really quick, I think it's important the board recognizes that it's page 6 of that document that's being added. Correct? That's, there's some recommendations that the board
Yep.
indicates that that's the only thing that's changing this version of this document.
Any other discussion? All right, all in favor signify with raising your hand. Or a yay. Since
Aye.
Brian seconded, I take you did. Okay, so it's unanimously adopted. Thank you all for your very hard work. That puts us, that's one more brick in the wall for now. I do have before we move on to the next item, quick question, actually, and I think this will be of interest to everybody. When is the annual report due in terms of a written form, and then the presentation to the Health and Human Services Committee?
That is due November 1st of 2021. And
Okay.
if
So we
we're
have
invited, the oral presentation of it would be at the interim committee meeting for the Health and Human Services Committee that's usually typically the second week of November.
Okay, so what we'll want to do is draft the written document, probably starting, give ample time mid-September, so that those we can review it and finalize it and get in by November. And and Rich, who will be responsible for that administrative activity this time around?
For a temporary period, we've asked Sarah Ponce on our team to fill in for what in the past has been an epidemiologist that's done that. And so we'll work with Sarah Ponce on that. And what we do hope to do is to hire a replacement prior to then. And it would be, there'd be some training that would need to happen in order for them to get adjusted and things, but we'll work with Sarah Ponce on making sure that happens as we prepare to hire someone else to be in that position permanently.
Okay, so I'll go with the idea, at least for the time being, that up and through maybe the September board meetings, activity will be reported out. We may have a chance to wedge in something from October if it's media meaningful and finalized enough. But I think starting mid-September would be reasonable for Sarah or others. So we'll maybe get that as an agenda item just to finalize discussion for the September for next month's meeting.
Yeah.
Alrighty. Melanie, that would be get on that.
Well, welcome, Dr.
the agenda.
Carlson.
And yes, so welcome Katie Carlson. And
Thank you. Apologies for being late. I had a little clinic issue.
no problem. We've gone through the welcomes, the approval of the minutes, and the approval of the autism spectrum disorder guidance. So and talked about briefly the annual report. So you're just in time for me to sort of summarize where we're at with the draft of the Alzheimer's disease document. Dr. Puckett, who made the presentation and reviewed the literature and the evidence. Unfortunately, I have not been, through multiple efforts of Melanie and myself, have not been able to connect with her. I do not know if she's on a long summer hiatus or what the situation may be. In any case, we did want her input and some help on her part would have been. Oh, and there's Dr. Lauren, welcome. Good to see
Hi,
you.
so sorry I'm late.
No worries. So we now have 6 of 6 of the board members. This is wonderful. So what I'd like to do under advisement is to proceed to take a shot at the sort of a revision and a review and revision myself. I'll just accept this as part of my duties at the moment to take and garner from that presentation the evidence that was presented to the extent it comports with the levels of evidence approach that we have adopted, and to maybe draft at least a revision to distribute to the board as a first go around over the next few weeks. From my recall, and if anybody has any other recollections, please do comment at this point. I don't think there's a lot to revise. There hasn't been much new or different with regards to the document that already exists that was circulated by Melanie for your review. However, it would be useful, I think, to format it now in a way that comports with the approach we've adopted for the last year and a half or so in updates, so that can be duly registered online, and everyone who follows this can appreciate that we what they're reading is the latest efforts to update with current and contemporary literature. So I will proceed along those lines unless somebody else has a burning desire to do so from the board. And all I will need, though, to do this is a copy of Dr. Puckett's presentation, which I could not find in my downloads. So Melanie, if you could go back through the archives, if you will, and see if you can find that, and Rich or Sarah might have it, but whatever is the easiest way for you to get it, and then just email it to me. I'll use that as a foundation to go ahead and at least provide a draft, and I will then distribute this to Drs. Woolsey and Rich as well as the board over the next few weeks, and then we can go back and forth and then have a discussion at our next our September board meeting. Is that
I'll see if I can
This is-
find, I'll see if I can find a draft of it. I only knew of it because I went back to the YouTube and listened to the presentation from May.
Yeah, there should be a PowerPoint presentation
Yeah.
that somebody's got somewhere, hopefully. I regret that I
Materials,
couldn't
right?
find it.
I'll look for it and try to find it and send it to you.
Yeah, Perry will work on that, and I will also work to help you connect with Dr. Puckett to help in maybe look at the next draft.
Okay, thank you.
Yeah, I'll
Yeah,
work on getting her. Yeah.
Thanks, I appreciate that. Okay, any other thoughts, comments about the Alzheimer's disease guidance update?
Hey, this is Ed Red. Is there any way you could get if you find the link to that presentation, could you get the link to all the board members?
Yes, I will.
Just for the sake of keeping things from getting horribly messy, doing things by committee is always awkward at the least. I'll try and do my best at a first iteration. If I've missed something and you pick it up from the presentation that you think should be in there. So we'll just go back and forth as we have with these. But if we all do it at the same time and concurrently, then it makes it very confusing. So anyway, and if somebody wants to take the lead again on this, please do. I just thought I'd volunteer since just to get things moving. All righty, now, I think, well, I tell you what, we're moving along at a pretty good clip here. So item 5 is consideration of content updates for any other indications or conditions that we want to proceed with. On my calendar, I have noted that we had been in contact, at least I believe I had, and our previous attempts had been made and accepted by Dr. Dan Odell in the Division of Pain Medicine and the supportive oncology program, palliative care program at Huntsman, to give us a presentation in September's board meeting on cancer pain. I will follow up with Dr. Odell and I'll copy you, Melanie, to get you in the loop and make sure he's still able. If for some reason there's a hiccup there, we can defer it. Again, it's nothing that's emergent or urgent, but we just want to stay on track. And I believe he was preparing that. So that will presumably be on September's agenda, and that will be, again, one more condition we'll review. I believe I'm going to get in touch with again, make never again to get in touch with Dr. Anna Beck, who runs the palliative care service at and is head of the palliative care program both at Huntsman and University Hospital, to see. She's an oncologist who's now exclusively doing palliative care, but I'm going to see if she will agree as an expert to review non-cancer pain symptom management, as well as the evidence for whatever it exists, if at all, in the treatment of cancer, primary treatment of cancer or adjunctive treatment of cancer per se. So symptomatic, non-pain symptom management, as well as primary disease management. And we'll see what Anna comes back with. I'll keep you apprised of that. But if she's willing to do that, October, November, December, I think that'll pretty much get us through the rest of this calendar year. Unless, again, there's a burning desire on the part of any board members right now to tackle any of the other indications that we have yet to review over the last year and a half or two. So I'll open the floor for discussion about that, or input or thoughts.
I mean, this is Ed Red. It sounds like a good plan so far. I think preparing for the report to the Health and Human Services Committee, I think, is pretty important too. And having that presentation like we have done in the past, make it, concise, but full of information that would be helpful, and letting them know what we've been doing. And then, it seems to me like every time we interface with anybody on this issue, they always kind of want an update about how things are going as far as the program itself, and that's outside of our board, obviously. But I think just letting them know that we're, making a good effort to stay on top of the literature and updating the guidance documents on a regular basis, I think is important. And I don't know, I've been on the other side of the microphone on those meetings, and it's just having a nice, concise report is pretty important. So,
Thank you, Ed. Yeah, and that, of course, that will be the plan. And Rich and Sarah, I'm sure, have their obligations for providing updates. From the standpoint of the Cannabinoid Product Board, there will be a written document, as we just discussed. I think we now have a very good formatted approach to doing it, and so there'll be just a lot of cutting and pasting with updating. Other than the just as a reminder, other than the conditions we've reviewed, which I'll outline in my very concise, well-practiced, well-rehearsed, because time is of the essence, and people tend to drift off after about 5 minutes. But then the discussion is where interesting things happen when there's a chance for it. So there will be a precise oral report that will summarize the written reports. But the only other topic was Karen Wilcox's review of topical administration of cannabinoids, and we'll just simply make mention, since that it's more of a delivery system approach rather than a condition. And we did have a very robust discussion about that. A lot of very interesting input from Dr. Viner about topical issues, but those have yet to move their way into the approved conditions. And I don't believe at the current time there will be unless something surprises me, I don't think we'll be recommending that a otherwise unlisted condition will be listed as a qualifying condition for the program as of this year. I don't think anything has changed that dramatically. So thank you anyway, Ed, for that reminder, and give me a chance to go in a little more depth on that. And now, without further ado, it really is a pleasure to welcome yet again our newest member of the board, Dr. Misty Smith, who comes to us about 10 years ago now with in terms of her receiving her doctoral degree from the Palmetto State. Is that correct, Misty, from South Carolina? And I'm going to hypnotize everybody with your outstanding vitals here. And just so bear with me, but I really do want to make sure everybody knows who you are and what your interests are, and not embarrass you by making you do this yourself. So I will be your spokesperson. So Dr. Misty Smith is a behavioral pharmacologist and a co-investigator in the NIH-sponsored anticonvulsant drug development, or ADD, program, where she provides leadership and expertise in all the preclinical models of acute and chronic seizure activity, as well as in the assessment of behavioral comorbidities associated with epilepsy. Dr. Smith coordinates the management of all regulatory and safety standards and licenses necessary to preserve the ADD program's high standards and scientific rigor and excellence in research. In hopes of better understanding the comorbidities of epilepsy and their underlying mechanisms, Dr. Smith evaluates the therapeutic potential of investigational compounds in both acute and chronic preclinical models of seizures, epilepsy, and the neuropsychiatric comorbidities of epilepsy. Dr. Smith's current research is aimed at the evaluation of the interactions of cannabidiol, CBD, with various classes of anti-seizure drugs utilizing isobolographic and pharmacokinetic analyses. The research will not only help provide information on the efficacy and safety of unique anti-seizure drugs, such as cannabidiol, both alone and in combinations with other anti-seizure drugs utilized in patients with epilepsy. The identification of novel compounds with broad or unique spectrums of therapeutic activity may also help, pardon me, to help better clarify the etiology of epilepsy and its comorbidities and the most effective targets for their treatment. Furthermore, understanding the nature of drug interactions will help identify better and safer drug combinations for the patient with epilepsy. Additional related research interests include the role of neuropeptides, steroid hormones, and sex differences in neurological conditions and their pharmacological treatment. That, my friends, is a mouthful. I did not do it all in one breath, but I'm working on it. And with such an esteemed group, I doubt I'll ever be able to summarize any of you with one breath. But Misty, thank you for joining us, for your expertise, your interest, and especially in this one area of epilepsy, which I know is of interest to all of us, because this is how Utah got its start in the cannabinoid sort of space. And as most of you all know, the only cannabinoid that's been approved, FDA approved, for a specific indication for epilepsy is cannabidiol, and it's the only indication as of yet that is FDA approved with an indication. So with all that, Misty, I'm going to have you turn over your slides to present to us, and we'll join on the conclusion of your presentation.
Wonderful. I'll go ahead and share my screen then. Bear with me. Okay.
We can see it.
Okay, fantastic. Well, thank you all. So today, I just wanted to share kind of I want to start out by providing a little background information on epilepsy, and really share with you why there was such a passionate plea from the parent advocates as well as the patient advocates and really the healthcare organizations and the various epilepsy foundations as well. So I hope once you understand that there is such a rigorous unmet need for safer, better therapeutics for the treatment of special populations in epilepsy, you'll see how medical cannabis related products like Epidiolex were able to very rapidly gain approval through the FDA. And I'll share with you some of that clinical trial data that led to that approval as well. So with that in mind, the title of my talk is Medical Cannabis Related Therapeutics for the Symptomatic Treatment of Epilepsy. And I want to emphasize symptomatic treatment as well. So it's important to keep in mind throughout this talk that although we have over 40 different approved clinical therapeutics for the treatment of epilepsy, right now it is just a symptomatic treatment of epilepsy. None of the approved anti-seizure drugs, going all the way back to the barbitones and phenytoin, they're treating the seizures, which are the prime symptom of the larger pathology, which is epilepsy. But we do not have a cure at this point. We can't treat the underlying pathological changes or the epileptogenic process that leads to the development of epilepsy at this point. So, and we'll talk about that in an upcoming slide. But right now we're looking for better, safer treatments for the symptomatic treatment of epilepsy. Okay. So I'm Misty Smith. I have an appointment in pharmacology and toxicology in the College of Pharmacy, as Perry mentioned. But I also have a joint appointment in the School of Dentistry as well. I teach pharmacology in their college as well. And some of my research is actually through that college as well. So towards understanding the unmet need for epilepsy therapeutics, it's a much larger impact on not only the American society, but worldwide. It affects almost 3 million people in the United States, over 65 million people worldwide. So that's 1 in 26 Americans will at some point in their lifetime develop epilepsy. Now, the most at-risk populations are the very young and the very old. They tend to have the highest incidences of seizure disorders. Epilepsy itself is characterized by 2 or more unprovoked recurrent seizures in a 24-hour period. So epilepsy, besides the seizure, actually, not only does it encompass a wide spectrum of different disorders, but it can also be caused by a huge variety of different etiologies. So we have this electrical disturbance in the brain, essentially, that is the seizure phenotype that we're all familiar of. And the seizure itself can range anywhere from an absence seizure, which has no outward appearance. It's just an abnormal spike wave pattern in the thalamus, or it can be a focal seizure, or it can be secondarily generalized or generalized and be the classic tonic-clonic or drop seizure that we tend to think of when we think of somebody having what was previously known as a grand mal seizure, which the terminology for the different seizure phenotypes over the last few years has completely been changed and rebranded in many different ways. But so the etiologies can range anything from genetic sources, genetic syndromes, to physical trauma, such as traumatic brain injury, stroke, viral infections. We're beginning to understand are large contributors to alterations in seizure thresholds. And this is particularly important in impacting nations where you have exposure to tropical infections and high fevers, especially in childhood. But also many metabolic disorders we're beginning to understand play a very significant role in the epileptic process. Besides the seizure, though, you have to keep in mind that this is really impacting the patient's overall quality of life, because comorbidities are very, very common in patients with epilepsy. And if you actually speak to either the patients or their families, many will say that the impact on the quality of life is actually more dramatic from the neuropsychiatric comorbidities that impact them as well. And depression is one of the key ones that impacts quality of life there. But there's also always a concern and undertone of the increased risk when seizures aren't appropriately managed for what's called sudden unexpected death related to epilepsy. This is, we don't fully understand the mechanism. We know it's related to the cardiovascular system, but in these patients, they just go to sleep and they do not wake up. It's a cardiovascular collapse during the sleep. And we're just now beginning to understand some of the risk factors that contribute. There's really a great need for more research into SUDEP and its causes and potential treatments. But there's a huge prevalence, particularly of the group of medically refractory epilepsy patients. These are the patients who have been treated with 3 or more appropriately prescribed and dosed anti-seizure drugs and have not achieved adequate management or adequate control of their seizures with this combination, concomitant treatment with 3 or more drugs. And this affects close to 22 million people worldwide. So if we look at this, the graphic at the bottom of this slide is actually showing how 50% of patients are actually managed with the first drug that they're treated with. For the patients who aren't adequately managed, they add a second drug on top of the first drug, and they typically gain an additional 13% of patients who are then managed. Adding a third drug actually only typically gains you another 4% of coverage. That leaves that 36% of patients who don't respond to 3 or more drugs. And by not responding, I mean either their seizures are inadequately controlled or they're just not able to tolerate the combination of the concomitant anti-seizure drugs that they're receiving. So it's really this one third percent of the population of patients with epilepsy that we're really not addressing their needs with the current group of anti-seizure drugs. And it's really why our program is still hard at work, looking for novel anti-seizure drugs, novel targets, and just really better efficacy and better safety profiles, alone or in combination, for helping this 1/3 of the population with epilepsy. And I also wanted to point out that it's this pharmacoresistant population, this refractory population, that we've come to understand are at the greatest risk for this sudden unexpected death in epilepsy, SUDEP, and other forms of epilepsy-related mortality. Whether it be drowning, whether it be asphyxiation, these patients, not only are they not being managed, but they're at greater risk for mortality related to the uncontrolled seizures. So one of the most difficult populations and most refractory populations are these rare, oftentimes genetic, pediatric encephalopathy patients who have seizures. And throughout my talk, you'll hear me talking about 2 different syndromes, Dravet syndrome and Lennox-Gastaut syndrome. So I included this slide just as kind of an overview. And I could do a whole lecture on both of these or one of these, but just so you understand, Dravet syndrome is actually a mutation in the SCN1A gene. 80% of patients have a mutation in that gene. And it basically causes this rare intractable, which just means pharmacoresistant epilepsy that begins in infancy, but will actually accumulate morbidity as the child ages. So it's not only severe seizures that are very difficult to manage pharmacologically, but also a wide array of behavioral and developmental delays, movement and balance issues, and dramatic disruptions of the autonomic nervous system. So these children have difficulty controlling their body temperature, their heart rate, their blood pressure. So you can understand why they really require lifetime care. So when you have a child with Dravet syndrome, for example, this is going to be, for the life of the children, just a huge impact, not only the child, but the family, because they require round-the-clock care, severely impacting the quality of life for the patient and the family. Lennox-Gastaut syndrome is another of these pediatric epileptic encephalopathies. It's also intractable, meaning it does not respond well to any of the treatments that we had previously for it, or combinations of treatments. The seizures are slightly different. These are more your tonic seizures, which is stiffening of the body. But one of the most common seizures are atonic seizures, which are really drop seizures. So these children they'll be walking along and they'll just collapse without the traditional tonic-clonic phenotype. So, but the Lennox-Gastaut syndrome seizures are sometimes difficult to diagnose at first because they emerge in childhood and they sometimes look like falls, but then their phenotype becomes complicated in that other seizure phenotypes are involved. But they do involve intellectual developmental delays and worsen over time. You see many behavioral disturbances such as hyperactivity, agitation, aggression, and there's a high comorbidity with autism in these children as well. As far as the cause go, it can have genetic causes. There's been several associations with mutations in genes, but there's also been evidence to suggest traumatic brain injury during birth or infection can also lead to Lennox-Gastaut syndrome, brain malformations. But at the end of the day, in about a quarter of this population, we really just don't understand. It's iatrogenic. We don't understand what the cause of their Lennox-Gastaut syndrome is. But again, it'll impact not only the child, but the child's family, because they will also require care. And our current treatments are limited in the benefits that these children gain, okay? So these are the two rare pediatric epileptic encephalopathies that the drug that Dr. Fine mentioned, Epidiolex, these were really the two patient populations that were really driving that strong parent advocacy mission to find a new hope, find a new drug for their children. So, because honestly, in addition to the 30% of patients with adult forms of epilepsy, these rare pediatric pharmacoresistant epilepsies, their options were even more limited because they were oftentimes on 4 or more drugs and not achieving adequate control and having higher than normal mortality rates. So that's where this huge unmet need was really coming from. Okay, so that's the primer on epilepsy, just from a 10,000-foot overview. I now want to talk a little bit about medicinal cannabis, and you've probably seen this presented in other places, but the take home from this slide is that we really have a long history with the use of medicinal cannabis for a variety of different conditions, but really going back over 2,000 years ago, or even longer, really, because the earliest documented use of cannabis to treat seizures was actually in a Sumerian text from 2900 BCE. And there's also a documented tablet in the Arabian language from the 12th century BC, actually describing the use of medicinal cannabis to treat seizure activity. So we can trace this back that far, but there's a long history of its utility throughout the years, as well as a wide variety of political changes that have impacted its availability as well as its clinical utility. So some of the more recent changes in present day have resulted directly from the evidence that was derived from recent 2015 to present FDA double-blinded controlled clinical trials on the Greenwich Pharmaceuticals compound Epidiolex, which is a plant-derived form of cannabidiol, purified cannabidiol, particularly in these rare pediatric epilepsy syndromes, which I've discussed. And the work that came from these clinical trials really led to their approval in June of 2018 for Dravet syndrome and Lennox-Gastaut syndrome. And actually in July 2020, there was an orphan drug designation. So not an approval, but an orphan drug designation given to Greenwich Pharmaceuticals for Epidiolex in tuberous sclerosis syndrome, which is related to cancerous growths in the brain and other regions of the body that are associated with developmental delays, cognitive delays, and pharmacoresistant seizure activity. So that's actually a third indication for Epidiolex. But I'll show you a little bit of that clinical data towards the end, but this is kind of your historical overview of where we were and where we are today, okay? Now, although we tend to, in the epilepsy community, be very hyper-focused on cannabidiol, anybody who is interested in phytocannabinoids like myself realizes that there's a lot more to the cannabis plant than just cannabidiol. There's between 80 to 100 cannabinoids plus more than 300 non-cannabinoid chemicals that all may potentially have some utility, even if not in epilepsy, somewhere else. We're really, there's so much need for research. We could research this plant for decades and still not understand how the entities work and how the combinations of the entities work, but that work continues. So I mentioned some of the chemical entities. Oftentimes they're subdivided based on their chemical structure or their psychological activity. Some are listed as psychoactive or non-psychoactive, and we can debate about that offline, but because they may be having activity, but traditionally when we say psychological activity, it's what causes the traditional high that you associate with THC compounds, and they tend to subdivide the different cannabinoids on if they're associated with those activities or not. The two most prevalent phytocannabinoids in the cannabis plant are THC and CBD. Tetrahydrocannabinol, which is associated with the psychological activities, and CBD, which is not associated with the psychological activities. And that is also one of the things that has made CBD more desirable for clinical development, particularly in children, is because it's not associated with this psychological alteration that leads to some of the effects that would be undesirable in children. But the thing to keep in mind is when we think of cannabinoids, we tend to think of actions at the cannabinoid receptors, which are labeled CB1 and CB2. So cannabinoid type 1 and cannabinoid type 2. But in addition to the actions at the cannabinoid receptors, with CBD, we're really in a unique situation because many of the clinical activities that we think it's having in epilepsy in particular are believed to be non-cannabinoid receptor mediated. They're having off-target or allosteric effects, and through a variety of different mechanisms, which I'll mention at the very end. And in addition to that, they're interacting with your endocannabinoids. So our body produces chemical entities, which is why we have CB1 and CB2 receptors in our body that really are involved in, I like to describe it as adjusting the gain of responses at synapses. So they really play a homeostatic regulatory role in the body, which really makes them great potential candidates as anti-seizure drugs, because they can really dampen hyperexcitability, and it tends to be activity regulated. So they tend to target synapses that are already hyperexcitable in their action. So this all contributes to why cannabidiol was desirable from a drug development standpoint. Okay, so when a Cochrane review was done of the clinical data that was available up to and through 2014, so prior to 2015, which is when the Epidiolex trials really opened and started. The review by the American Academy of Neurology and Cochrane in the Cochrane database concluded that medical cannabis is of unknown efficacy to treat epilepsy. There were really just a handful of small clinical studies that had been conducted. Some of them were double-blinded, some of them were not. But usually the patient size was quite small. And I've outlined the ones that I was able to actually find good descriptions for. So with 4 of them, patients were usually 9 patients, 15 patients, 12 patients, 12 patients. Some involved control groups, some did not. So some of these were actually more like case reports. But the data was somewhat limited. And some showed that and they were all looking at cannabidiol particularly, not looking at a botanical product, but actually at extracted cannabidiol in a variety of different patient populations, in doses ranging from 200 to 300 milligrams daily, usually always orally delivered. Only one of the studies used a crossover design. That was the one by Tremblay et al. But all of the reports that I could find were very limited in any information on the adverse effects observed, but they also had contradictory reports of its ability to manage the seizures in these studies. So this is what led the Cochrane report to say there's no significant evidence to show that there was activity leading up to 2015. Okay, this is when the purified extract was being developed and characterized by Greenwich Pharmaceuticals out of Cambridge in England. Okay, so cannabidiol or Epidiolex really is the first FDA-approved cannabis-derived treatment for seizures for these rare treatment resistant. So they have very clear indications. They're really approved for patients with Dravet syndrome, Lennox-Gastaut syndrome. They're 2 years or older, or most recently, and I actually, this is a misnomer. It's an orphan drug designation, not an FDA approval. So let me clarify that. I need to actually change that. I missed that earlier. For tuberous sclerosis complex in patients 1 year of age or older. Patients are given a proprietary oral solution of a purified plant-derived cannabidiol in oil, and it's very well tolerated, up to 25 milligrams per kilogram daily. The most common side effects observed are sleepiness, decreased appetite, and diarrhea. In a small population of patients, they did see liver enzyme changes, particularly transaminase elevations that were remediated with dose adjustments. So as soon as they adjusted the dose, they were able to bring the liver enzymes back into the normal levels. Epidiolex was originally Schedule 1. This was changed to Schedule 5 in October of 2018 as a result of the early evidence from the Epidiolex trials. So just briefly, in the trials, this basically summarizes the first 2 trials that were done. focusing on Lennox-Gastaut syndrome in the first trial, and Dravet syndrome in the second. These patients were in both studies treated with 20 milligrams per kilograms per day. The dose titrated, typically starting at 5 and titrated up to 20 over 11 days. This was a randomized, double-blind, placebo-controlled trial, and patients were scored on a variety of different indicators, but in the percent symptom reduction, you saw really a reported improvement of their overall condition. So this is self-reporting in this instance. 43.9% of patients in the Lennox-Gastaut study and 43% in the Dravet study improved overall improvement. The percent adverse effects are high, but again, these were generally mild with the exception of that liver enzyme elevation, which was adjusted with the dose adjustment. So the results from those studies are available, they're published. And if you want more details on those, you can look at the 2 references that I've provided. To look at these a little more in detail, I've provided, this is actually from the reported, this is from the FDA website. And I provided the links below, but this is the efficacy data that led to the FDA approval of Epidiolex in patients with Lennox-Gastaut syndrome on the left and Dravet syndrome on the right. And what you can see is if you're looking at the mean percent change from baseline, so the number of seizures they were having at baseline, you see more than a 2-fold decrease in the number of seizures that were being observed in your treatment group. And when they did a dose escalation study, they were able to maintain this. And these reduction in seizures, they actually did a chronological study out to 3 years, and they were actually just able to show a maintenance in the 2-fold reduction of seizures out to 3 years. I didn't show that data here, but they were able to show a significant reduction out to 3 years. In the Dravet syndrome patients, you actually saw a 3-fold reduction in the median change from baseline. So keep in mind that these are children who were on an average of 3 to 5 other anti-seizure drugs and inadequately managed. The seizures were not being controlled on that combination of 3 to 5 other drugs. They were left on those drugs. The main alteration you saw is because of a drug interaction with another entity that's used for the treatment of these conditions called clobazam, a pharmacokinetic interaction. Many of these patients did require a dose adjustment of clobazam because we've learned since these trials that Epidiolex actually causes a pharmacokinetic interaction that leads to an increase in blood levels of clobazam, particularly the active metabolite of clobazam, norclobazam. So a simple dose adjustment is what was required to bring them down and to reduce the sedation, which was the main side effect they were experiencing with the increased plasma levels of clobazam. So they were reporting tiredness, essentially lethargy. So this was very, very promising. People were very, very excited about this in the field as well as patient groups. For tuberous sclerosis complex associated seizures, again, this is the new orphan drug designation that was granted. You saw a similar benefit in the treatment group with Epidiolex. And in this graphic, they actually showed what other drugs, the most commonly concomitant anti-seizure drugs or anti-epileptic drugs these patients were on. You can see with having 4 different drugs on board, they still weren't adequately managed until you added in Epidiolex, and then you gain this 2-fold reduction in their seizure activity. So this is really the clinical data from the GW Pharmaceutical sponsored clinical trials that led to its approval in these indications. Okay, so I think there's strong evidence from these particular clinical trials specifically for Epidiolex, okay? But to point out, Epidiolex is cannabidiol, but it's a proprietary formulation of this extract that in the FDA approval is specifically for Epidiolex. It's not for other cannabinoid or cannabidiol products, okay? There is one other, this is a synthetic cannabidiol. It was produced by Insys Therapeutics, which is no longer in business. They filed I think it's chapter 11 bankruptcy, and I may be misspoken. I don't understand bankruptcy law, but they in 2020, I think it was, filed bankruptcy. The synthetic cannabinoid product that they were developing, an oral solution of purified CBD, had been granted orphan drug designation for the treatment of Lennox-Gastaut syndrome and infantile spasms. I wasn't able to find any data on where it was at with the FDA. It has been taken up by a different company along with the opioid products that Insys was producing. But I hit a dead end trying to find any of the clinical data or finding out where this compound is now in development from this other company. So I can't share any data with you on it because I wasn't able to find it through any of my resources. I just wanted to share it because it is out there and it does have these orphan drug designations, okay? So just to wrap up, I wanted to share what the preclinical research has shown are the most likely contributing mechanisms to the cannabidiol anti-seizure effects. Interestingly enough, as I mentioned, these are cannabinoid receptor independent mechanisms. Many of the anticonvulsant effects, a lot of the model work in rats and mice have indicated a role of GPR55 mediated presynaptic calcium release. So basically quieting neuronal firing through dampening presynaptic calcium release into the channel, or modulation of adenosine signaling, which also happens to have anti-inflammatory effects. And as many of you probably know, epilepsy itself is highly associated with inflammatory changes in the brain. So the anti-inflammatory effects that are associated with cannabidiol is also, I'm sure, contributing to its beneficial effects in these patients. And there's also been evidence to support its antioxidant and neuroprotective effects. And I showed you through some of the mechanisms and reductions. It has a variety of other mechanisms that may or may not be contributing, but you can rationally see where they could benefit a patient with epilepsy. There's effects at the serotonin receptor. It modulates endogenous endocannabinoid systems in that it's a potent enzyme inhibitor for the enzyme that actually catalyzes anandamide, which is one of our endocannabinoids, increasing the endogenous endocannabinoid levels. They believe that actually is beneficial in a number of different pathologies, not just epilepsy, but antiemetic, anxiolytic effects as well. So the take home is there is strong clinical evidence for Epidiolex, limited, if any, evidence elsewhere for other cannabinoids. When I did a search on clinicaltrials.com or .gov, I was actually able to find 49 studies with cannabidiol in epilepsy patients. 4 of those have been completed. Only 1 of those is recruiting. 16 were terminated and 4 were withdrawn. So there's still some work going on with other cannabinoid products. I'm sure including the INSIS compound and others. But data is very limited outside of Epidiolex. When I did a similar search for tetrahydrocannabinoid, THC, basically I was only able to find 2 clinical trials, one of which was terminated, the other is actively recruiting. But if you actually read into the study, it's actually a 1-to-20 combination of 1 part THC, 20 parts cannabidiol. So it's really looking at the effect of the combination instead of just the cannabidiol. And this is being done in Canada up at the University of British Columbia and some of the other Canadian neurology groups to see if there is a very limited, they refer to it as an entourage effect, but it's only the combination of cannabidiol and THC. It's not including any of the other cannabinoids, which a true entourage effect would be the effect of all the cannabinoids working on one another. So this is the evidence that I was able to find. Again, I feel it's strong for Epidiolex, very limited and insufficient for other cannabinoid products for the treatment of epilepsy.
Well,
Thank you.
Misty, thank you so very much. I'm sure I share the thoughts of the rest of the board and others attending, that this was really an extraordinarily important review and very timely. And I'd like to actually take the prerogative of the chair to give a quick anecdote. I see Sarah's hand up, and we'll get to Q&A in just a moment. But you mentioned INSIS. I guess it was about 4 years ago, maybe 5 now, that I had an interest in, based upon some studies that were going on in Europe, mostly Spain, looking at apoptotic, or basically cancer cell killing effects of CBD in cloned adenocarcinoma of the prostate cell models. And I ended up going through the very lengthy, rigorous process of getting DEA Schedule 1 research approval and license, if you will, to study that. And the only source of CBD, because it was Schedule 1 at that point, was INSIS's synthetic CBD, which was a perfect source. And after all that effort and just about an IRB approval, I mean, at the university, everything was set in motion, both for treatment of the disease, but it was for stage 4 metastatic disease. So really a no harm, no foul kind of model, and as well as to look at symptomatic benefit potentially from its maybe anti-inflammatory effects. The INSIS ended up in this felonious legal trouble with actually
Yes.
the CEO is now in prison, in federal prison.
Sure. Yeah. I just didn't want to go into all.
Yeah. So that shut down the whole program, and you know,
Yeah. Yeah.
anyway, I've got my own sort of sad saga and that sort of put an end to that. But so let's move on to Q&A. Sarah, your hand's up. Please proceed.
Yeah, Misty, thank you. That was great. Just a quick question on the 2 trials that are on the screen now. Are they kids or adults or both? Are they adults now, or do you know?
So the one that's active is in children. I believe the age range was, I want to say 1 to 18, but I don't have the ages in front of me.
Okay.
But it is in children specifically.
Okay.
The one that was terminated, I didn't really look into it as much because I don't think it ever got off the ground.
Okay.
But the Canadian study is looking in children, and I know Tilray is one of the companies that's really pushing in Canada for the pediatric utility of many of these products. One product that I didn't go into great detail about, but is a really, from the preclinical side, a lot of development going on. And I know GW has a compound in the pipeline from the epilepsy meetings I've attended. It's cannabidivarin. I've actually published some preclinical data on it. I didn't show you any preclinical data or any of the drug interaction data that I have in my rat and mouse models, but cannabidivarin is another entity that is in rapid development in the pipeline. It's in models of, they're looking at it in epilepsy, they're looking at it in spasticity. So you'll be hearing more about cannabidivarin products in the near future, I would predict.
Yeah, and I would just want to, for the sake of this discussion, we can take it anywhere you guys want to go. We've got probably another several minutes that are available to do this. But from the standpoint of the Cannabinoid Product Board, remember, we are dealing exclusively with cannabis-derived extracts that have been formulated with either relatively high THC to CB to low CBD, vice versa, or intermediate, intermediate of or equal of each. So these three different sort of varieties, and probably to some degree everything in between. But we are really not dealing with any purified extracts with pure CBD. So this is really not an issue, or THC or CBV or CBG or any of the other myriad cannabinoids. Everything is a mixture, and if there's an effect, the so-called entourage effect that Misty made mention of is really a synergy. And there's really interesting and fascinating receptor-related activities that are, unfortunately, poorly understood, really, from the standpoint of the molecular basis of those receptor effects, where they may be amplified, attenuated. Obviously, that we do know that there's a lot of interaction between THC and CBD effects at receptors. Some are allosteric, some are orthosteric, as Misty mentioned. But this is opening up, it's just a world of fascinating and very important research, especially because of the homeostatic nature of endogenous cannabinoids and the effects of modifying them to any degree once we start inserting exogenous cannabinoids, no less other agents that are involved in in cannabis. So anyway, I thought that as an aside is important, because we really don't have access to,
Yes.
if you will, pure CBD in the Utah program. Anyway, I actually have a couple of quick questions then while people are formulating their thoughts. Not to get too hung up on this, but it's just fascinating to me. I wasn't that aware of it. The sudden death involved in. Do we know what the frequency is amongst? You mentioned it in the kids and the two rare pediatric disorders, but amongst this fairly large group of individuals, living with seizure disorders in the U.S. and then globally. What's sort of the annualized death rate that's attributed to otherwise unexplained deaths? Do you know?
And I don't know that off the top of my head, but that is known, or it's at least estimated based on what's been observed through the people who are doing that research. There is a percentage associated with SUDEP. I just don't know it off the top of my head, but it has been reported by the Epilepsy Foundation, which I'm happy to follow up with you and let you know what their report is. I just know that percentage more than doubles in the pharmacoresistant population compared to patients who have managed epilepsy.
It might be useful to, as we work through this process, to add some of this kind of detail to the guidance document. Just it really helps inform readership about, both the urgency as well as the medical necessity. So that would be helpful. And I'm curious again, just ideologically, how do we know that these are cardiovascular deaths rather than, say, a respiratory death? I mean, anoxic, hypoxic death, especially during sleep. I mean, it would seem to me intuitively it's more of a hypoxic event or respiratory event. But do you have any thoughts about that?
Well, that's what's proposed from the preclinical models. I don't think they know for certain, because oftentimes these children are passing away at home. They're not passing away in centers where they're being monitored. So this is their best hypothesis at this point based on the preclinical models, which aren't great, admittedly, for SUDEP. Actually, our program, Dr. Cameron Metcalf, who is our associate director, is trying to improve upon some of the current models for SUDEP by looking at some of the animal models that tend to have more refractory seizures. And he's having a really difficult time reproducing what's been published. So there seems to be some strain and species dependent differences that are impacting. So, I mean, there's always challenges when you're trying to extrapolate to the human what we're modeling in the rodent. And I think that in the mouse, it may be more cardiovascular. In the mouse and rat, there may be, I'm sure that the cardiovascular and the respiratory system are both involved. So I think you have to kind of have an asterisk next to that, that it's not just cardiovascular. We don't really know if it's cardiovascular, respiratory. We just know it has some involvement in it. So.
All right, and my last sort of question that for clarification purposes, from your talk, and maybe important in terms of, sort of making the documentation around this and the guidance document maybe a little more robust. Is there any evidence for any of the myriad classes of anti-seizure drugs, the ASDs, that are being used, including the gabapentinoids? Is there any of those classes that seem to be more favorably synergistic with CBD, with Epidiolex, as it's currently being used, and or a higher therapeutic index in any one of these classes? Because as we start adding all these drugs, there's obviously a lot of metabolic pathway conundrums that we face, as well as expense, and cost is just out, off the roof. So your thoughts on that, Misty?
So yeah, so as far as the clinical evidence goes, there's that pharmacokinetic interaction with clobazam, where it increases the plasma levels of the active metabolite, nor-desmethylclobazam. So that interaction, they believe, is strongly contributing to the improved median seizure reduction in those patients. But I think there's evidence for interactions such as the clobazam interaction. I know that seizures can actually be worsened in some of the patients who have these conditions who are on sodium channel blockers. So we typically don't give sodium channel blockers to some of these rare pediatric encephalopathies with or without Epidiolex being on board, just because if you have deletions or mutations in the sodium channel, they tend to actually have their seizures worsened. So, I mean, I think we're still beginning to understand the drug-drug interactions in the human. I can tell you in my animal models, I have been able to show interactions, but I haven't really seen good translation of that to the human. So in my animal models, I see a very strong synergistic interaction with Keppra, levetiracetam. But when I go back and try and pull that data out of the clinical trials in the patients who have had Keppra on board, I don't see the same synergistic activity. So I'm left with the conclusion that that might be the difference in the rat versus the human, or the mouse versus the human per se. So the strongest evidence for an interaction is what's been in the human is what's been reported by Teal and others from the clinical trials with the patients who are already treated with clobazam, and then they add Epidiolex on. And we know that for a fact to be a pharmacokinetic interaction.
So just to follow up on that, and again, thinking about the guidance document, I'm sure, and maybe people like Ed and Brian can weigh in on this too, that there are probably guidelines for first, second, third
Yes.
choice select drugs in different epilepsy conditions.
Yes.
And so where and how would CBD or high CBD, low THC ratio products for somebody in Utah who's now as a card holder and can go and get product, what would be what would our guidance document suggest in terms of adding and titrating a cannabinoid or a cannabis product based upon those epilepsy or anticonvulsant guideline recommendations in terms of titrating up one and titrating down others? What kind of, if they were to call you and say, "Oh, great pharmacologist that you are, give us some help in managing this patient," what would you think would be the best advice to give them?
My first piece of advice would, they need to discuss that with their physician rather, but, from what I understand from the epileptologists that I've spoken with, it's being given adjunctively. And if I can go back to, let me see if I can go back to the tuberous sclerosis slide that I showed. There is, and when I follow up with the information on SUDEP, I can follow up with the recommendation for, this is the drug you start on, then you add in this, you add in that. That is characterized in some of these encephalopathies. But my understanding is that, and any of the clinicians can correct me, but I understand it as they're using the Epidiolex almost adjunctively with these others, that it's not necessarily the first line. But that's just what I've understood from the meetings I've attended and from personal communications with some of the pediatric epileptologists that I've spoken with.
There's a question that Mark Viner has.
Oh, Mark, before we get to you, any other board members? Sorry, Mark, I just want to make sure we.
I just want to, Misty, that was a fabulous presentation. I learned more about epilepsy than I learned in medical school, which was a long time ago. I just want to clarify, you're saying no other CBD trials panned out, just this one. That's, you're pretty clear on that.
I have searched and searched. I have not seen any other clinical trial data even conducted. I mean, if I had found negative data, I would have reported it as well.
Yeah.
I
Okay.
haven't turned it up.
And then just kind of stepping back in terms of board, kind of plugging this into some of the kind of views of the board, or the kind of direction the board's going in. THC and epilepsy symptoms, there's nothing there either as far as your research, or are you less familiar with that, or what?
So as far as, if you read the literature or the reports, the case study reports, you can find case reports showing that there's evidence of it improving, evidence of it having no effect, and evidence of it making it worse. Again, epilepsy is kind of an umbrella of a whole spectrum of different seizure phenotypes and etiologies. And I'm sure that it's the disparity in the effects has to do with they're treating these. None of these are randomized double-blinded clinical trials. They're just treating, small groups of patients and generating case reports. And I think that's why the Cochrane studies and others leading up to 2014 just said that there was not sufficient evidence for, I forget what their exact wording was. It was, that the medical cannabis is of unknown efficacy. And it's just basically because there's such a disparity from the case reports and from the small studies that happened up to date, which I summarized on the next slide. But those, when I really dug into them, those weren't looking at THC, those were looking at CBD again.
So,
And
sorry, go ahead.
no, they're to find the studies on THC, you see them referred to, but I was never actually able to find the original studies to report them. The ones I spoke here were ones I was actually able to go to the original studies and verify what was done. I didn't really feel comfortable presenting anything on THC because I couldn't actually find the
Yeah.
information. It was just in a publication, they would mention the same, almost the same sentence. It's almost like people were, repeating what was published elsewhere, that there's
Right.
mixed effects with THC. It improves some seizure phenotypes, has no effect on others, and benefits others. But I couldn't ever get back to that original source.
Yeah. I found the same when I delved into the PTSD literature. But so then what do we do with that? Because there are patients and families and parents who are desperate. I really like the way you framed this about why this is such an important heated issue, and that the current treatments are not adequate.
Mhm.
What do we do with that when there are patients who swear by this, or parents who swear this is what is saving my child? What do we do with that? I mean, I see some of the same. I mean, I think that issue can apply to a lot of things that THC is kind of being promoted for, beyond seizures caused by epilepsy, almost any condition. There's the passionate anecdotal case study type of
Yes.
data, and we're seeing that. I mean, now it's been 2 years, and we're seeing that in every
Yes.
condition. What do we do with that, specifically with kind of the seizure issue?
I think that the case reports for the high CBD, low THC strains, like what was presented by Sanjay Gupta in the Charlotte Durgi story, the weed story that he did. I mean, those are very compelling,
Mhm.
and the effects were very dramatic. But there's always that cautionary asterisk that it's not a controlled, clinical trial. But and when you talk to some of the epileptologists in Colorado, where a lot of individuals went to Colorado early on because access was better there than in Utah, for access to some of these. They caution that it's really more, there's so much variety depending on, what product the patient is actually getting and what type of seizures the child actually has, that it's really hard to make a general statement because of the lack of control in the studies. Where does that leave us? You can't deny the benefit that it's had for some individuals, but you also can't say that there has been, a really thoroughly vetted clinical trial to support its utility. So there's going to be this disparity in the data, because you need to understand exactly what's going into each patient. You have to understand the relative ratios. I think when in the patients that are receiving CBD, I think the Epidiolex studies support that I have little doubt that CBD is having a anti-seizure effect in certain types of seizures. It's just difficult with the botanical products because there's purity concerns, there's contaminant concerns, and it's difficult to really know who's getting what. But it's, I think there's benefit if we know what's the patient's receiving.
Yeah.
Well, thank you, Misty. We're going to let Dr. Viner have the last word because he's been
Yeah.
waiting patiently, but I just, on sort of a commentary note, you know, there is a lot of angst around this sort of desperation that patients with intractable conditions and often in terminal conditions
Yes.
face. And of course, the motivation for this advocacy group of especially moms with kids with these devastating diseases was very compelling. You know, the Charlotte's Web strain, was a high CBD, low THC strain that came out of you know, these growers in Colorado. You know, it was providential, and there was a signal, and the anecdote became a signal that was then followed, and it turned out that signal had meaning. When pure CBD or an extract from plant-based CBD and by GW ended up panning out. Would that all of the various signals that exist end up panning out in such a way? And that's the nature of the clinical trials that are ongoing. I think from the standpoint of where we have to deal with our angst, and maybe as you know, you, Katie, is more of a psychiatrist, can maybe manage our angst better than most. But from my standpoint, how we should be managing our angst is through, you know, following the evidence where it takes us, and using the process that we've entered into over the last few years to continue to make progress to guide both healthcare professionals as well as the public towards making healthy decisions for themselves given the program that exists and the kind of products that we have. You know, so that's, I think, what we can do. And I think it's not subtle. It's a very meaningful contribution. Would that we could cure all ills. I mean, but on the other hand, to believe that cannabis in one form or another is a panacea for all ills
Right.
is problematic. So I think our role is to be balanced and as scientific and objective, and to continue on in the vein that Misty just did, which is provide the evidence, the literature, have a thoughtful discussion, and then document what we can for the sake of those who have access to information or need access to information from our program. So with that, Misty, and then Mark, I promise we'll get to you.
Can I add one thing?
Of course.
I think one of the best things we can do as a board too is emphasize the importance to patients of being smart consumers and understanding exactly what they're getting and the importance of rigorous quality control standards. Because it's particularly with the botanical products, understanding the purity and understanding independent third source verification of content is going to be absolutely critical to a patient being able to use anything botanical with any level of safety. And this is why being a smart consumer of these products is so critical, you know, because you know, it could be the Wild West if people aren't understanding what they're getting.
And it was the Wild West. I mean, we can go over a little bit, but I think that's an important discussion. Early on, when the first legislation went through for CBD oil to be allowed to come from Colorado to Utah and for these patients, it was not well regulated, and we had no idea what dose, what contaminants, what quality. There was no quality. So at least, and very importantly, and you know, Rich, when your section comes up in a minute after Mark, we can talk about the importance of the quality assurance process. And what's one of the reasons we wanted to have the educational program for the board members with the agriculture department and the pharmacies to assure us and let us know what these products are and what that process is, because we've been running along for a couple of years now, more than that now, with and we're sort of playing catch up with our level of understanding. So we could go on and and I'm guilty of going on and on, as you know, but Mark, Dr. Viner, let's cap off the Q&A before we get to Rich Obern's summaries.
Okay. Thanks. That was a great presentation. Just a couple questions. Can you hear me okay?
Yes.
All right. Some of the safety reasons, some of the safety issues, like with liver function tests monitoring. I know you know that they updated where you got to get before you start Epidiolex, and then 1, 3, and 6 months after, because some of the LFT damage doesn't occur for many months either. And then even if you change the dose of the Epidiolex, you got to get LFTs. And it goes back to the valproic acid problem, which goes back to Dr. Fine's question about where does it fit and other. So yeah, I would definitely not mix it with Depakote at all, unless you want to do genetic testing for mitochondria, POLG syndromes, which are contraindicate valproic acid. So valproic acid, I wouldn't add it to that. The clomazepam's more like Valium. I wouldn't add it to another sedating anticonvulsant or Valium or benzos. But I think I'm finding Topamax, Topacrack, they call it, that's stimulating and then mixes well with that, or a neutral anticonvulsant. You actually got to lower the Topamax dose. I think. So I would fit in with maybe a second or third agent, but you got to be careful what you're adding it to. No sedative type anticonvulsants, or you got to watch it and adjust the dose and do liver function monitoring. So, and then one other question with the new work from Stanford, I think part of the problem with where does THC fit in is you got to break up, like you were saying, Ms. Smith, the type of epilepsy. There's new work with THC for hippocampal seizures, like mesangial temporal lobe epilepsy. Now, none of it's double blind, placebo, but there's going to be more work using THC a little bit more with hippocampal seizures, because it stops the glutamate and relaxes it. And Stanford just published 2-AG, that's the natural endocannabinoid, is released after seizures, and it calms the brain by that mechanism, glutamate calming. And that, but they get memory impairment, confusion, like your post-ictal states, like stroke-like symptoms, forgetfulness, which kind of makes sense with 2-AG. So I think, but for non-temporal lobe, for your regular, frontal and other, then you can, you see the CBD is much more useful as you presented. So one question, I think that's pretty much it. Oh, what do you think about the cumulative dosing with Epidiolex over the months? Like with Charlotte Figge, she died. She was 15 and died. I was wondering if the cumulative dosing of this medicine over long term, is there anything new with anything that you would monitor? And then finally the STAR 1 and 2, where they use topical for seizures. That was presented in a poster last year. Any comment on that? Okay, thanks. It was a great presentation.
Thank you. So there are a lot of questions in there. So I'll try to make a few notes as you were speaking. So as far as the drug selection process goes, another key piece that you have to factor in is for these particular conditions that we were talking about, Dravet syndrome and Lennox-Gastaut, not all anti-seizure drugs work for them. Okay, so there is a handful that have mild to moderate benefit. So they tend to be given adjunctively. Those include drugs like valproate, which you mentioned you would avoid. But since there's so few drugs again, these are pharmacoresistant epilepsies. So having no other choice, they're willing to use things that we rationally wouldn't use had we better options. They had no other options previously, so they used them even though they had increased adverse effects with them. So valproic acid does have some benefit in some of these. Vigabatrin is another, which has its own collective set of potential adverse effects. Levetiracetam has mild benefit, and clobazam has benefit. We know that there's an interaction with clobazam. I've already talked about that. So these are the ones. So I pulled up the slide with the tuberous sclerosis. These patients had a median of 4 AEDs that they were on when they added in Epidiolex in this study that led to the orphan drug designation. And we're currently uncontrolled on a median of 3 of them. So, you know, you're really looking at a milieu of many different of anti-seizure drugs being on board in these patients when Epidiolex is added on. So this is why you have the elevated sedation and all of that in these young children. The doses are titrated up to until and then stopped when these adverse effects begin rearing their head in the studies. So I'm sure there are accumulations, and they watch these kids out to 3 years in the follow-up study that was done in the Dravet patients. And they continue to do the dose adjustments as needed based on their response to the drugs in that study. So I believe that's a process that the patients taking this are ongoing when they're taking it. As far as the Stanford study, the hippocampal seizures, that was a wonderful study that was conducted. Something to keep in mind, though, is because of the circuitry that's involved. So the hippocampus, in many of the generalized seizures, become involved regardless of the original focus of the seizure. So this is why that particular study was so interesting, because it's actually going to have effects not only on individuals who have a focal limbic origin, but also in any patient who has a generalized seizures involving the hippocampus. And these patients are the ones who tend to have more of the sclerotic changes in the hippocampus and a lot of the comorbidities associated with cognitive deficits and depression, et cetera, associated not only with the changes in the hippocampus, but also in the amygdala and other limbic regions. So important work, but I think that you have to keep in mind that in the indications that Epidiolex has, these are genetic mutations that are affecting the entire brain, not just the hippocampus. So, and with these kids having such a increased risk for SUDEP and other mortality, that the compassionate use clauses, this is why they went forward with it.
Misty, I'm going to interrupt only because we have now lost half of our board because of obviously scheduling things. And important and interesting as discussion is, certainly Mark, I'm sure that Misty would invite discussion offline.
I apologize.
I know there, but also we're at the top of the hour, and Rich was on this schedule to talk about research database development and other policy topics. I think unless, Rich, there's something that absolutely urgently needs to come to our attention and be on the record for this meeting, we'll maybe defer until September for your update, if that's okay.
Yes, there's nothing critical, so.
All righty, and you know, if there's any, using the term again, if there's a moment of angst here from anybody on the public side who wants a comment recorded into the record for this meeting, we'll give it maybe another minute to do so. Otherwise, I think we will move on, because although we did get a late start, I know people do have other scheduled activities, and I said we've lost half our board to that at the current time. So Misty, again, many, many thanks. This was, you've shown your brilliance, and I know we all are patting ourselves on the back for making sure you got on the board. You just proved your merit in the last hour. Thank you so much.
Yeah, thank you. And I apologize for going over with
Oh,
the
no, it's not your issue. It's just the fact that we did get started 22 minutes late, just to be exacting about it. So that's the way life goes sometimes. So do I see anybody else's hand up? I do not. So I think at this point, at exactly 11:02 Mountain Time, we'll call it an end to the official meeting. And just remind everybody, please go ahead and sign off. Dr. Woolsey, Rich, Misty, Dr. Smith, and maybe Melanie, stay on board. We've just got a couple little administrative things we want to chat about for a minute offline. And we wish everybody good health, and we'll see you in September as the
Thank you all.
says. Thank you all. See, Clayton, I saw your hand.